evening, and the reason we have organized this event, it's obvious there is a lot of confusion around the vaccine, and people want to find out what is the right advice, what's the right information, and if there are any issues to be clarified, then we've got the right people here to answer those questions. Manaar is a faith-based charity. We have a mosque based within the Manaar, but also activities that generate benefits to the community takes place in the Manaar Community Center. Most people probably heard about Manaar through the Grenfell Tower fire about 3.5 years ago, that tragic fire, but it's been there for the last 20 years. So it's part of the community. It's a community organization managed by the community for the community. And we are very close to the community. So we are also in a better position, hopefully, to communicate with the community and become a bridge between the community and the different authorities, including the public health, our doctors, our national and local governments, and so on. So this is what we can do today, I hope, and we'll come out from this session with enough information to allow us to make an informed decision whether the vaccine is the best option for us, but also whether there are any issues of concern that we may need to be aware of, and so on. So with that, I think I'll pass on back to our facilitator for today, Dr. Jasmine, and the rest of our speakers. Thank you very much and welcome again. Thank you.
Thank you, Abdurrahman. That's fantastic. Voting is now open and I'm starting to see people bring their questions in, which is fantastic. So do use that link I put in the chat. I'll share it one more time so everyone can see it on my screen. And it's going to make life so much easier for everyone. It is, oops, oh, we can't see everything there. Community immunity, the code is 535199, or you can copy and paste from the top, and I'm going to just copy and paste it again into the chat so you can literally click that link to start. Okay, so my name is Jasmine Razak. I am the clinical director in North Kensington, and I look after the area around, as Abdurrahman said, around Manaar, but also around the Grenfell Tower, and up towards St. Charles Hospital. We have a community of 42,000 patients, and we work very closely with the other local communities, so really one big primary care network. I'll be chairing today, and the principle of today really is to learn together, to support each other, to understand and get the answers to the questions that we really need to get answers to. There's a lot in the media, all sorts of media, and there's a lot of fear, a lot of worry, and it's understandable. We've been through a very hard, past 12 months. We're nearly now at a year on since the first case in the UK, and we need to, of course, move forward. So we're really lucky today to have absolutely fantastic speakers. I'll introduce them one by one. They have about 5 minutes each, maybe a bit more, maybe a bit less, to talk through their particular area. So handing over now to our first speaker, Dr. Sarah Elkin. She's an integrated care director at Imperial College for North West London. She's a respiratory consultant. She's also a close colleague and has her heart very much in the North Kent community, and works at the St. Charles Hospital supporting patients with respiratory conditions, also at the hospital at St. Mary's with COVID. So she's one of our local experts on COVID and also on long COVID. So handing over to Sarah for 5 minutes to give you an update on effects of COVID. Thank you, Sarah.
Thank you, Jasmine. Hello, everyone. It's so fantastic to see so many lovely faces out there on such a cold evening. Hasn't it been beautiful today? It's been so fresh and good and lovely and white and crisp. Anyway, lovely to see you all. I've been asked to talk to you about how COVID-19 has affected individuals and is affecting our hospitals. So I'm going to start by talking a little bit about some reflections. I thought, because before I came on, how has this affected me, and how has it affected the people I work with, and how has it affected the communities that we are part of? So let me start with a personal reflection. I had COVID in March 2020, and being in an oldish group, was scared. I was scared of becoming unwell, and why was that? That was because I'd seen how this disease can really affect people. In the weeks before I became unwell, we had a tsunami of patients coming in. breathless, unwell. We didn't really understand it at that point. And this was very scary for them, their families, and us. It was scary because they were on their own. We weren't allowed to let relatives in. And this has been one of the most heartbreaking aspects for me. The rapidity of onset of the disease is scary, and how long it can sometimes take to recover. So one of the myths I often hear is, you know what, I'm too young, this isn't going to affect me, I'll just get through it. And in fairness, the majority of people get through COVID very easily. You know, they get through well, and within a fortnight, they're all fine. However, there are some people that do not. It definitely affects the older age groups. It definitely affects more Black, Asian and minority people. Now, the latter, we don't know why. It may be jobs, it may be communities, myriad reasons, and we're learning together about this. So where was I? I was unwell for about 2 weeks, went back to work in about a month, and fortunately was fine. But I jumped at having the vaccine, and I gave myself a New Year's Eve present. I went to work on January the 1st and had the vaccine, and I insisted on my husband having it too. And I actually worked out my biggest risk of having the vaccine was actually the drive into the hospital. So always think about relative risk to yourself about having the vaccine and how it may affect you in a different way. What's been positive about this? The positivity really to me has been how communities have come together. And I know that someone mentioned Grenfell earlier. To me, the communities came together after that awful event. And I think in the NHS, we've come together so much after and during COVID. The staff are absolutely amazing. They've worked together, we've worked across boundaries, we've had volunteers, we've had people that have never worked in intensive care going up to intensive care. And really, really and truly, it's been incredible to see how people have come together through this. Back to the point about how it may affect people. I deal mainly with discharge from hospital, so I see when people are getting better, and I see also people in follow-up clinics. I see people that have been in hospital, and also those that have been seen by primary care or your GPs. The people from primary care, many people were not seen during wave 1 in a hospital, and they got on with this disease in their own home, and they've had myriad or many symptoms since then. Many of you will know this as long COVID or long haulers, and about 10 to 15% of people that had COVID, which is many, have these symptoms, which are breathlessness, dizziness, odd chest pains, and understandable anxiety about what this may be. We've now set up clinics for this, and again, this has been fantastic, seeing the staff coming forth from therapies to help with this. I'm often asked about who is admitted to hospital. We've spoken about this, and really it's everyone. I think this disease does not choose who it affects. It can affect any of us if we are in contact with this. Do we see more elderly? Yes, we do. Do we see more Black, Asian minorities? Yes, we do. But we see anyone, and we see all age groups. Where are we with numbers? Terrifyingly, our official death toll in London is now around 12,000, and this is likely to rise further. And my sympathies go out to any of you who have had a loss during this time. At the moment, about 1 in 30, perhaps a little bit more, are affected or actively infected by this disease. And there is ample evidence now that the new variant is more transmittable. So you're more likely to be able to catch this new variant than the old one. So do be careful with masks and space. The numbers are falling in communities, but please be under no illusion, you know, unless we fight this virus together, we will get more waves. It's just going to happen. So we have to use all the weapons, all the ammunition we have to fight it together. Currently, Imperial is caring for approximately 485 people with COVID-19, and about 139 of those are on critical care. Just to put this in perspective, we had 360 at peak of wave 1. We now have 485. We have many more people in hospital. And over the next 2 weeks, that's unlikely to go down. So staff are being redeployed from other areas. What does this mean? This means it's put immense pressure on the NHS resources, and we're having to cancel outpatients again. And whilst on this wave, we've continued with emergency heart attacks, emergency strokes, other things have had to stop again, and we don't want this. So whilst people say the bed occupancy is no more, the bed occupancy is more, and it's different. We've had a barrage of people that have been really, really sick, and therefore that puts a strain on other things. For example, if other people would have a car accident now, they'd come to hospital, they'd been put on intensive care if they needed to, but they might need to be moved out of their local area if there was no ITU bed. So this can affect everyone of every age, and that is why it's so important that we do address and explore vaccine. So we do feel that there is a light at the end of the tunnel. We really do. I think healthcare workers are exhausted. Again, we're really fully supporting each other. And you know, Jasmine and Manfred will say that as GPs and secondary care healthcare workers, we're working together and supporting each other, and it's truly wonderful. So the reason why I'm here again is that I feel strongly that vaccine is one thing that can help us as a community get back to a new normality. So I really hope that the rest of the speakers now will try and convince you that that's the case, and please do ask me any questions that you might have.
Thank you so much, Dr. Elkin, for that update, and really important points there about the rate of COVID locally at the Imperial Trust. North Kensington is a top 5% hotspot nationally. So where we are now, we're really very much at risk, particularly in North Kensington itself. I'm going to hand over now to Samira Ben Umar, who's Head of Engagements and Partnership at North West London, and to really focus in on the local impact now, if that's okay, Samira, of COVID on our area. Yeah,
good afternoon, everyone. It's absolutely beautiful outside despite the cold weather, so thanks for joining us. I suppose I just wanted to share with you some reflections and some work that we did here in locally around the impact of COVID, both during the first lockdown, but also kind of the continuing impact on our communities. I mean, as Sarah mentioned and as Jasmine mentioned, North Kensington not only is suffering from the impact of COVID, it's a kind of a cumulative impact of both COVID and the impact of Grenfell. So when right at the beginning, what we wanted to do was begin to capture some stories from local people on the reality on the ground. What is happening? How are people experiencing it? What's the impact on families, on communities, on the individuals, as opposed to just the national narrative that we're hearing about, you know, the information that people are sharing in terms of stay indoors, you know, wear a mask. So what is happening on the ground and what's the reality on the ground? So we captured in-depth stories. We looked at the data, but we also captured the stories of specifically from our Black, Asian, minority ethnic groups. We worked with mosques, we worked with temples, we worked with churches. We also worked with local voluntary and community organizations. And what came through was very, very clearly right at the beginning was the issue of every time we spoke to people, the keyword that they used, we asked them, what is the keyword that you want to use? And it was fear. The fear in terms of actually kind of not knowing and understanding what is going on. The second fear was actually the disconnect between us as communities and our system. There was a real anxiety and what I would call there were two epidemics, if you like. There was a real epidemic in terms of what COVID was doing to our communities. And the second epidemic was the epidemic of the misinformation that was shared out there. There were so many short videos that were doing the rounds in WhatsApp groups saying, if you go to hospital, you die. This is what happens. Your faith will not be respected if you die in hospitals. And sadly, we had so many people who stayed at home who died. And people were sharing these stories of us, of families who have lost loved ones as a result of the anxiety of not actually kind of seeking help early on till it was too late, or people died at home as a result of that. Just to say that actually it may feel like that's moved on. That hasn't. We're still hearing stories of people actually just last week one of my husband's best friend actually passed away. He waited till too late and then had pneumonia and ended up in hospital and passed away in hospital, sadly. There's still the anxiety that actually if you go to hospital, you die. So it's a self-fulfilling prophecy. You wait until too late because you have a lack of trust in the system. And then by the time you enter the system, things are really actually quite critical. So that's just in terms of the anxiety and the fear of people. There's also people have shared with us around the mental health impact. You know, people are living in overcrowded and multi-generational household. People have lost loved ones, and there hasn't been the space to just grieve or to go through the rituals. And that has a mental health impact now, but also we don't know the impact in the longer term. So really thinking about what does that mean in the future. And the final one, just in terms of the volume of information that we're getting and the trust is, who do you trust? What type of information that's happening, that's taking place? How do we trust that information? There's still a lot of anxiety about that. So there'll be questions and I'm happy to answer questions afterwards, but I just kind of wanted to just share, just kind of almost kind of an ask, just based on the hundreds of stories that we've heard, the feedback that we've had from our communities. It's just, I mean, my first ask just of our communities and our system is just, you know, read was the, you know, Iqra was the first word that was revealed to the Prophet, peace be upon him. Read. So my ask of our communities is read, search, look at the sources of information. YouTube and short, you know, 30-second videos going around WhatsApp are not information. So we have a duty to actually kind of really search and read and actually identify the sources of the information that we get and act on the information that is right. Second, mobilize together to actually kind of share the right information. And for those who have had the vaccine, share with others your experience, share with others the impact that it has on you. Because I really think that that's the only way we're going to really address this issue. The final one is really demand more of us, you know, challenge us, you know, to make sure that actually we deliver in your image, because you are the taxpayers, you deliver, you are the ones who are paying for the services that we provide. So demand more of us, be more proactive in actually engaging in the conversation with us. We need to move away from this thing of, you know, we hear a lot in our system, hard to reach. Usually it's easy to ignore. We are, as a community, are easy to ignore. So we really need to mobilize and be proactive in really working with the system to make sure that it delivers what we deserve as a community. So I'll just stop there and I'm happy to answer questions later on.
Thank you. I'm making lots of notes actually as we're going along, if that's okay. Okay, so yeah, completely working in partnership, and I guess that's what we're here to do today. So very much one community coming together, learning from each other, and yeah, we are here to serve. So please do put your questions for Samira and Sarah. And Sarah has put it in the chat actually. It's a really good point about the fear of hospitals and late presentations. Please do not be scared of hospitals. The treatments are much better and people go home. And I think that's a really good point to make. The second wave is, in some regards, is different to the first. We've learned a lot from the first wave. Don't be scared. We are here. We are working differently. Yes, we are redeployed. We are in different roles, but we're all working around the clock to support. So I'm going to hand over at this point to Prof. Harun Shah, who is a retired professor from Public Health England, whose wife is Prof. Sahir Garbia, who works at the Public Health England. They work in tandem. So we brought Prof. Shah in rather than Prof. Garbia because Prof. Shah has a local connection in the Notting Hill community, playing in Carnival. He plays in the nostalgia steel band of lots of the patients who you may recognise him on the call today. And he's just going to talk a little bit about things outside the vaccine we could do to prevent getting COVID. Over to you, Prof.
Thank you very much, Jasmine. And thank you very much to the panel as well for inviting me as the only non-medically qualified person to be on this panel. My lifelong career has been in basic science, and I've taught biochemistry and microbiology at the Royal London Hospital Medical College for 20 years before going on to Public Health England for the last 20 years. And to emphasize what Jasmine has said, yes, I have worked actively in the Notting Hill Carnival area. And what both Sarah and Samira said is absolutely true. I get calls every day from the Notting Hill Carnival community about fears about the vaccine and fears about going. In one case, my daughter and myself, we took our steel pans to the house of one patient and played to actually get him out the house, and he's happily out of the house. It's Jasmine's patient and now had his vaccine and is a completely different person. So as a basic scientist, my purpose here is just in a very few minutes to perhaps just crystallize some of the information that you have been seeing on the, let me just see if I can share the screen. Yeah, that you've been seeing on television and so on. Oops, yeah. So you've seen these pictures all the time of someone sneezing and the aerosol that's created as, oh, sorry, that's, let me just go back up to the top, yeah. So here is a person sneezing this aerosol, this large amount of bacteria and particles that come out, and the first thing that would tell you that if that happens in a closed place, it's likely to spread and very easily to a second and third person and so on. And so we'll talk about the mask in a few minutes, but let's just, this is a picture you've been seeing all the time. Now, this is an experiment I used to do for the students for, my God, about 15 years at the Royal London Hospital Medical College. That number in the right-hand corner is 150 students. Now, what we used to do is to take a flask, just an ordinary glass flask, a glass, and dip it into a suspension of bacteria. So, and that's an agar plate, it's just jelly, you don't see anything on it. If you press your fingers onto that plate and then leave it at 37 degrees overnight, you'll see a fingerprint come out of the bacteria that lives on the skin there quite naturally. That's our normal flora. I'm not sure if you see in the right-hand corner, there's some red bacteria there on that plate. So what we used to do was to then just dip this flask into these red containing bacterial suspension. It's completely harmless, and then pass it around the group. And as it went through everybody, they'll press their fingers onto the plate. And then when it reaches the last 150th person, it could go on longer, they would press their hands. And what this did immediately to the students is, this was very early in their career, it made them appreciate that process of transmission. And there's two things I want you to bear in mind. On the left-hand source, what you always look for as a microbiologist of infectious disease, the source and that process of transmission. And in this case, you can see how widely and how easily something is transmitted from one person to the next. We never took it beyond 150, but I have no doubt it will go on and on. So the first lesson, when the Prime Minister is always saying, wash your hands, you can see what is being said right there at the moment. I'm not getting the slide to move down. I don't know why it's, okay, right, I'll take it this way then, yeah. Now, in previous, we know, I just highlighted two cases here. The case of one of the best known infectious diseases, not the best, but the most frightening one, the bubonic plague, caused by a bacterium called Yersinia pestis, in which something like over 100 million people were killed. And you can see what is being done even as early as that time in the map below, is that process of transmission. So again, what you would do, look back to where that source is. Initially, people were saying it was rats. We know it was infected fleas and so on. And you try and cut off that source so you prevent the transmission. On the right-hand side of the screen there, there's an example of something that we're facing right now, and a high level of TB right in London, as an example. We know that over 1.5 million people die every year from TB. And yet, as you know, we were all vaccinated with BCG years ago. It's no longer very effective in many parts of the world. You might have also seen on the news regularly that badgers are being culled. Why are they being culled? They are suspected as perhaps sources of carrying the bacterium, Mycobacterium tuberculosis, through the next phase into cows and so on. So this is what you are constantly trying to do in the process. Now, let's look a little bit now following that. So in the case of COVID-19, we know for a start that the source here is not clearly defined because we are still in dispute of where that might happen. It could be from a bat, it could be from pangolins, it could be from various mammals, we don't know. Let's ignore that for the time being. What we do know, and is abundantly clear, is what is going on, human-to-human transmission. And that is why it is so important to listen to all the messages that are coming out all the time. We could forget the source for the time being. We'll find out about that later on. But this virus, without a doubt, shocked everybody at the success at which it's able to carry on this transmission process. Now that process of transmission, where a virus or bacteria comes into a human site, is not just a simple case of it just landing and it gets absorbed. The body puts up a lot of defenses to prevent that happening. And the vaccine, as they'll say, one of the prevention methods, but it's a very specific process which will take hours for us to just even talk about a virus or bacteria landing on a site and what goes on there. And it's really...
I'm so sorry, Prof, you've cut out, you've gone on mute there. Hello, Prof Shah, can you hear? You've got on mute there. Can you unmute? Prof Shah, can you hear us there? You've muted.
Yeah, okay, can you hear now?
We can.
Yeah.
And just to say, just one more minute for our next speaker. Fantastic.
Right, so human-to-human transmission is absolutely clear. We have no doubts at all about that. Now, Sarah mentioned also about the, let me just see if I can get this to move on again. It's stuck again. Oh, I'm not sure why it's not moving. Right, okay. Mention about the variation. Now, you'll see that little diagram on the right-hand side. These are trees that we use just like hereditary trees to try and trace the sources. And every little change, the closer like B and C are together, it means those two are highly related and that could subdivide and so on. The analogy here with the parakeets is a good example of adaptation and selection. Parakeets are not native to this country. They came in a few years ago into the Thames Valley, and everybody assumed that one winter they will die away and they would not be a problem anymore. They have adapted, certain species have selected, and now they are all over, particularly in Brent and in western parts of boroughs in London. On every treetop you can see them. It is the same thing that is happening with the virus. The virus itself is adapting. Today's news, you would have heard that both the variants from South Africa and Brazil are up here now. So even though you have the vaccination, you're being told that we should still continue to behave as if we don't, as if we are in lockdown and haven't had it. And one final slide to just finish off this. Oops. Yeah. Yeah, are you able to see that one? It's just this process of controlling transmission. So what we want to do is disrupt that source. Masks have been, you've been told this nearly every day on television. Hopefully the process of washing hands, social distancing. I would add to that, which you don't hear a lot about. Air travel is something I personally wouldn't do at the moment. Ventilation at home, and particularly closed spaces, we hear this all the time. And hopefully to mitigate all of this as well, vaccination has been started, is well underway. I've had my own vaccine vaccinated on Friday. Its impact on transmission is that we should still continue to treat it, as I've said, as if we haven't been vaccinated to prevent others. But hopefully in these 2 minutes or so, some of these processes that you've been hearing a lot about might enable you to see why it is necessary to follow the steps that we are being told to do almost every day. Thanks very much.
Thank you so much. I think that's such an important message. So the vaccination is part of this. and we've got to make sure that we're still following hands, face and space, and reducing that transmission. We're now going to hand over to Dr. Ibrahimsa. He's a specialist in infectious disease, as going to talk about the critical mechanisms of how the vaccines work, and also talk through the safety. We know there's lots of mistrust, as Samira has said, and some of the questions are very interesting that are coming in. There's lots of misinformation. So Uma's going to talk it through with us and help us understand the actual basic principles of vaccination and the methodology and what that means for us. Handing over now.
Thank you for that, Jasmine. I wonder whether we can do a bit of a thought experiment. I want you all to imagine that you're 300 years back, it's still snowing outside, you're sat in the middle of New England in Boston, and all around you is a raging epidemic. There are 844 people who've died already. Some 6,000 people have caught this disease, passing on from one person to another, dying of fever, suffocating almost. And amongst a small group, for some reason, they've managed and been able to survive their exposure to this illness. Now, what is it about this group? Well, this group happened to come into contact with a man who originally came from West Africa, a man called Onesimus, who had been brought over on the slave ships across the Atlantic, and after that arduous crossing, ended up working for a priest called Cotton Mather. And there in 1721, in the midst of this epidemic, in the heart of Boston, Onesimus managed to convince Cotton Mather of the efficacy of inoculation. Here is a man from West Africa, 300 years ago, providing a means for challenging our immune system, improving its response, and enabling it to overcome significant infection and saving people's lives. This West African managed to reduce the incidence of disease amongst the people he inoculated from 1 in 7 people dying of this to 1 in 40. Now that is no small achievement. And at the same time that he was doing this, you could easily wander around the villages of Bengal in Eastern India and see men going, or women actually, going from house to house, again, inoculating young children, protecting them from the threat of infectious disease. And the same again could be done in East Asia. And in 1716, whilst she was sat in Istanbul, then Constantinople, at the heart of the Ottoman Empire, Lady Mary Wortley Montagu managed to see this in action and was sufficiently persuaded to have her 5-year-old son inoculated in 1718, again, 300 years ago. And this is a process that was regular, that was normal, that was routine, that was part of these societies. We see it in West Africa, we see it in the Middle East, we see it in East Asia, all over the world. And that brings me to the point of what is vaccination. So vaccination is a way of enabling your immune system to overcome the challenges that it will face when it is affected by an illness. So giving a weakened form of a disease, a weakened form of an infection, or exposing it to part of a germ, so that when it really meets that infection subsequently, it can mount an effective response and protect that person. And that's what vaccination is. And you'll all be familiar with it from the childhood vaccinations that all young children undergo. And the way that we don't see polio today in the UK, that we don't see diphtheria. And tetanus is not the killer that it used to be less than 70 or 80 years ago. So these are things that work and things that are familiar to us. And I think we should take some security from that this is not something entirely new. Now, let me share my screen with you. Is that visible?
Yep.
This was what Onesimus was preventing. This raging inferno of a rash that goes from one person to another, that transforms healthy children to pockmarked, scarred individuals for life, if they even survive it. And this is what was overcome 300 years ago by this man from West Africa. But let me take you on a journey. And the journey I want to take you on is a journey into the cell, into the very heart of our being. Here in front of us is the unit of life. And here at the middle of it is the nucleus. All around is an impregnable barrier made up of fats called the cell membrane. This double-layered membrane is what holds everything else in. And there's no way in or out of it except through tiny portals with their gatekeepers allowing passage through. And then similarly, there's this membrane around the cell, and you can see the holes here that allow passage from what's inside to the cytoplasm outside. And this is the gift from generation to generation. This is the means that the cell controls its response to the world by commanding how it produces proteins. So imagine it like a vast library with these tiny scripts, these messages being sent out all the way around to these protein-producing factories around the edge. And as that script is read, these factories manufacture proteins that are then used either at the membrane or elsewhere within that cell. But that message, a bit like a letter to James Bond, self-destructs. It disappears within about 48 hours. That message, that mRNA, lasts only a few hours within the cell. So what has this got to do with vaccination? So the two vaccines that we have, one produced by Pfizer and one produced by Moderna, are vaccines that contain bits of mRNA, this fragile molecule that rapidly disappears, and somehow manage to get that into the cell. And the way they do this is by coating it in a lipid layer. That lipid layer comes and collapses into the cell membrane. It doesn't need to go through those portals. It just merges in and like a ghost passed through and into the cell itself, and then disappears. That lipid layer disappears, revealing the mRNA, which makes its way down to the ribosome, and they then produce the spike protein. So what you're getting the cell to do is produce a protein that would normally appear on a virus. And because it's abnormal, because it's not something the cell normally produces, that protein is taken to the surface and shown to the immune system. And you have an immune response and you start producing antibodies. And your immune cells recognize anything that might produce this and would kill it. And then another way of getting it is like the Oxford vaccine does, where it uses a virus that does not replicate. It comes, it infects you, and then introduces this, again, little script that is then made up, used by the ribosomes to produce more of this spike protein. And in that way, produces an immune response. So these are very, very clever vaccines, but they're not entirely new. The Pfizer vaccine has been in research for at least 10 years in one form or another, as has the Oxford one, and then has been, with a sideways shift, used in the current coronavirus epidemic. So knowing that, how safe are they? Well, I don't know if you can see this slide, but over 30,000 people, actually 45,000 people have been vaccinated with these vaccines in the trials leading up to their public use. And today, at least 5 million people have been vaccinated in the UK. And we've not had any reports of severe side effects. We've not had any deaths associated with this. But what we do see and what we expect to see is the immune system responding to this, producing swelling at the site, maybe a headache, bit of fatigue, fever, and nausea. And most of these stop after 2 days. So the vaccine is safe. It follows a well-established tradition. And this is a tradition that communities all around the world have been using for the last 300 years. And with that, I will hand back to Jasmine.
I was really enjoying that. I was hoping going for a bit longer actually, but maybe in the questions and answers we can get some more. I love that storytelling technique. That's a very powerful story. Thank you very much. So again, questions and answers, if you can, please put them in the Mentimeter. We've got about 23 questions in there. I see some are putting questions in the chat, and that's fantastic. Please do put them in the Mentimeter so we can get them answered, as many as we can. When they're in the Mentimeter, you can upvote them so we know which ones are the priority questions for the group today. We have over 145 with us. So Emma, if you just unshare your screen, I think I can do it like that. And I'm going to go into our next speaker. We've got 2 speakers, and then we're going to go straight into Q&A. The first one is Geoffrey Lake. He's a Deputy Director of Public Health in the boroughs of RBKC and Westminster. And then he'll be followed by Dr. Manpreet Bains, who's our North Kent Recovery GP, a local GP, again, looking at the data and the numbers and really how this vaccine is being rolled out in the area. So handing over now to Geoffrey, followed by Manpreet. Thank you.
Thank you very much, Jasmine. It's a pleasure to join you this evening. Perhaps also in this context, I should mention that I'm also an associate priest at St. Bride's in Fleet Street. So my thanks to Manaar for showing such leadership amongst our faith communities. Really, really great to see that. I actually lead some of the outbreak management work for our boroughs, and in particular, working with our care homes and our hostels and sheltered housing schemes. And since the new variant that you heard about at the beginning, which, as you heard, there is now very clear evidence of increased transmissibility. It's certainly extremely challenging to contain outbreaks in those settings, very difficult days for many of those premises. So the vaccine really is a very welcome development. It is very much our way out of this pandemic. So what of the Council's role in terms of the vaccine rollout? Well, of course, the NHS is very much the lead agency here, but very much supported by the councils, both in terms of the vaccination sites themselves, and those are of a variety. First of all, there are local sites through your GP practices, and then larger mass vaccination sites, as well as hospitals. And in our boroughs, so at present in Kensington and Chelsea, we have the Earls Court Health and Wellbeing Centre, the St. Charles Centre for Health and Wellbeing, and the Violet Melchett Clinic, and in Westminster at South Westminster Centre for Health and at Lord's Cricket Ground. And there are also plans that are well advanced for mass vaccination sites in our boroughs as well. So one at Marble Arch and one in South Kensington. And the council, apart from supporting these sites, is very much involved in communications to residents and support of our communities. I think there are some very positive signs. It's around 90% of those who are offered the vaccine that receive it at present. And there is very clear national evidence which shows that those intending to receive the vaccination has increased significantly in recent months as people have recognized the benefits of vaccination. So we're very much involved with those efforts to make sure that our communities understand that these are vaccines that have very good evidence of their safety and efficacy. And then I suppose just finally I should mention in terms of health inequalities. So we've heard earlier from Samira, who mentioned the disparities that COVID has shone a light on, and it's very much the case that we are seeing a disparity in those who are receiving vaccination, and this does threaten to be a driver of further inequalities, because that will inevitably lead to less protection in those communities. So we are very much involved in events such as this, and indeed sharing communications and resources to ensure that communities and individuals have the information that they need. Thanks very much.
Thank you very much, Jeffrey. And again, questions for Jeffrey, please do put them in the Q&A. We now have nearly 30 questions coming up, so if you can upvote your questions, we're nearly there. So Dr. Baines is going to take over now and just share some slides around what Jeffrey was talking about in terms of the uptake and the importance of the uptake in our different groups. So Dr. Baines, just to say, when you do share your slides, do press, do slideshow, so you can see, thank you very much. Thank you. So Dr. Baines is our, I have to spotlight you actually if I can, is our, again, North Kent Recovery GP. She works very closely with me. We are delivering the vaccines. We are the frontline doctors at the St. Charles Hospital, supporting you to get your vaccines and running the centres. So I'm handing over to you now, Dr. Baines.
Thank you so much, Jasmine. Just to check you can hear me okay?
Yeah. Fab.
So my couple of minutes really mirrors Jeffrey's actually, and so instead of repeating the messages, I'm just going to build on them. So the first point is around how to access vaccination for COVID, and really the key message here is wait for us to contact you as the NHS. And so here on the slide you can see this lovely ladder of how we're starting off with vaccinating our population. So at the moment, we've been calling in all our over 80s. We've been contacting those and going to visit those who live in care homes and vaccinating our care home staff. NHS staff as well are being offered the vaccine to protect them in the work that they're doing. And we're now going down into our 75 plus cohort. As you will have seen on the government messaging, by mid-February, the aim is to reach down to our over 70s plus those who are shielding, so clinically extremely vulnerable, and fingers crossed we're on track to do that at the moment. So when the NHS contacts you, and that will be maybe perhaps by phone call, by letter, by text message, so each of those sites that Jeffrey mentioned, they're contacting people in different ways. So when the NHS contacts you, please do sign up for the vaccination. And in terms of our local area, Jeffrey's mentioned the 3 primary care sites, and the nearest mass vaccination site at the moment is Brent, with a few opening more locally soon. I'm just going to touch on now the second point really, which is around data. And we are really monitoring our data carefully, okay, because we know that COVID-19 has really shone the spotlight on inequalities, and really we're focusing in on a few key areas. So age, and we're moving down our cohorts as we intend to vaccinate. But really there's 2 other things for me. One is that we know that people living in areas of higher deprivation are more at risk of COVID. So we really want to ensure equality of access to vaccine. So there's really something about ensuring our access is equal across Northwest London, but then there's also something about encouraging uptake. And so we'll be doing many of these over the next few weeks, these talks with our community, and really encouraging people to take up the vaccine. And the slide that you're seeing here, on the left-hand side, is the area in North Kensington. It's North Kensington basically, and where Manaar is based, and covers the geography that Jasmine and I work in. And so the red really represents areas of higher deprivation. And on the right-hand side are the clusters of GP practices that cover those areas. We really do want to try and see equity of vaccine uptake going forward. So we're closely monitoring that. And then really there's something here about on this slide where we're up to at the moment. So this data flows through every few days into our systems. And what we're seeing here is these slides here are looking at deprivation and going from 1 to areas of highest deprivation through to more affluent areas going down the slide towards 10. And what we want to ensure on the left, that's Northwest London as a big geography. And here on the right is our area. So it kind of mirrors Kensington and Chelsea borough pretty much, our CCG area. And what we want to look at again is just make sure everyone in our population is being both offered the vaccine, and we would like to see people taking up the vaccine as well, equally too, if possible. And my final slide here is ethnicity. So we know certain populations, certain communities, certain of our communities have been hit harder. And so there is some work for us to do, I think, looking at this slide. This slide is our borough, so our borough of Kensington and Chelsea, looking at the uptake of the vaccine in over 80. So I should have said all these slides are our 80+ cohort so far. And really, if we look at this, there's something that stands out for me at the moment, which is that looking at our community of Black Afro-Caribbean communities, do we need to do a bit more to work with our communities to really support them in asking the questions around the vaccination and whether they have any concerns? And we're looking, Jasmine and I are looking, and the team here, to do some talks going forward with specific communities. So if you would like to, if you're on the call or the seminar today, if you would like to reach out and come and do some events with us, we'd love it. So I'll hand back to Jasmine now. I think that's it from me. Thank you.
Thank you. Okay, so we're going to go on to the Mentimeter, and I want everyone to start filling that Mentimeter in properly. So I think we had a question on our Menti that we prepared for everyone. So let me see if I can bring it up on my screen, and then we can share that with everyone on today. So the question really, so what Dr. Baines was just saying to us is, well, what about access? What about, you know, are we getting enough access to our vaccine? Hopefully we are. We're the delivery team. We want to make sure we get you the vaccine, and that's our job. How do you want your vaccine to get to you? Is the question we want to put to the audience today. So on that Mentimeter, I'm going to go see if I can go forward. Let me see if I can now share my screen. Share screen 1. There I am. I can't spotlight myself, Manpreet, so if you can spotlight me, I can't see my camera. Okay, here we go. So how likely, at the beginning, this is not now, how likely I take the vaccine? So of those on the call, we have about 7 at the beginning. We'll do that again at the end. Lots of questions we're going to go through shortly, but this question for us is really important. And please, please, please fill it in now, because that will inform as well our discussion. So where would you prefer to have the vaccine? So we're currently running ourselves at the St. Charles Hospital. It's a beautiful setup in Ladbroke Grove. As Jeffrey said, we have 5 of these set up across Kensington, Chelsea and Westminster. So that's, I guess, a local hospital, a site, St. Charles Hospital. Do you want to have it in your GP practice? Do you want to come to our surgery? And I'm so glad to see that people do want to come to our surgery, because you always worry that people are currently worried about coming to primary care. So actually, that's a nice one to see that people really want that. Do you want to have it in a community space or centre, somewhere like Manaar or a temple or a church? Would you like to have, because it's a nice, open, big, clean space for you to go and have your vaccine? Do you want to have it at a pharmacy on the high streets when you go and collect your medications? As we do, we give flu jabs there now. Can they also give us a vaccine? Do we feel confident that that's a location for us? Or what about these lovely mass vaccination sites? And I guess people probably don't feel they're lovely yet because it's 3.2. And I guess they're new, aren't they? They're probably unsure about that at the moment. So please do fill that one in. And that's really, really useful information for us, because we want to make sure that you can access your vaccine, because there is one for every one of you when it's your turn. Okay, so we're going to go on to the questions now. Now the questions are, someone's like, my sound keeps going into Dalek mode. I hope, Ela, you can hear me. I hope everyone else can hear me. It may just be your Wi-Fi possibly on your end. I'm not too sure. I hope. Can you hear me? Samir, you're nodding. You can hear me, yes?
We can hear you very well.
Okay, good. Sorry if you can't, but we're just going to go on to the Q&A now. I think is a good time to open up for a panel discussion. So if all the speakers, I'm going to unshare my screen, here, and if all the speakers can put their cameras on, and everyone who's not speaking keep their cameras off so we can see our panel together. I think that would be wonderful. And then I'll bring up the questions. Okay. Lots of tricky questions for you all. So I'm gonna, if you can, someone can unspotlight me, that'd be fantastic. Dr. Baines, me unspotlights. Need to make sure everyone's spotlighted. How do we spotlight everyone? How do we bring everyone together? Too sure how, actually. Cancel the spotlight. There's the button. Cancel the spotlights. So if we do that, hopefully we can see everyone, I hope. Okay, so going to hit you with some tricky questions, guys. I hope you're ready. That's what we're here for, isn't it? To understand what the questions are from our audience. So hopefully lots of our questions will be answered by the talks. I'm going to go for the ones that have been upvoted the most. I think we'll do it in that order. And we've got about half an hour now for Q&A. Of course, if we can't finish those questions, we'll keep going after the event. Someone was asked specifically, can we type them up and send them round? We normally do that with our doctors' teams when we run these webinars. I haven't got anyone typing at the moment, but if someone's happy to type them up on my behalf and email them to us after, then definitely we can circulate them round. So anyone who's good on their computer, please do. So, do the vaccines affect women of childbearing age to have children and get pregnant? And do they affect their unborn baby? Who would like to take that question? And seeing as you're on spotlight there, I wonder if we hand over to you. And seeing as you have lots of beautiful children as well. If you unmute yourself, thank you.
So currently, we'll not be vaccinating any pregnant women. And as with any vaccination, these are never trialed in pregnant women because we would like to ensure that they're entirely safe. We believe they're safe, and never place a unborn child at risk in this case. So in terms of whether they would affect individuals who have childbearing age, they'll provide them with immunity against coronavirus and protect them from developing coronavirus, which in individuals who are of childbearing age, and we see this in the late stages of pregnancy, are at risk of developing severe disease. So yes, it will affect them, but it will affect them positively.
Thank you. And that is obviously, as we know, every day it's changing. So that will change and you'll be able to, hopefully, if you're pregnant, have your vaccine soon. But what Amira is explaining is that we're doing it slowly, we're doing it carefully, we're doing it in a planned way. You'll be screened when it's your turn. At the moment, we're not giving many people their vaccine under the age of 70 anyway. And by the time it becomes your turn, then that may be an opportunity for you. So I'm going to go to the next question. Ooh, is it possible to choose the type of vaccine? Who should I ask that one to? Who wants to take that one? I don't mind. I don't mind. I guess Dr. Baines and I can answer that one. Yeah.
So at the moment, we have 2 vaccines that we're offering. We started off with the Fisa vaccine a few weeks ago here locally in Kensington, in fact, the whole borough. And that was being offered to people who are mobile, who could come to us. It's a little bit more difficult to transport around because it has to start off in a very cold temperature and it's not allowed to be moved around that much. But we're now getting supplies of the Oxford AstraZeneca vaccine, which is a little bit more easier to transport. And that one, we started off by using that for our housebound patients and patients in care homes. And we're about to start this week offering that to people who come to us. So in essence, the supply at the moment is what comes in and that's what we're giving to patients. But I don't know, Jasmine, if you want to say any more.
Yeah, and I would say we asked this question, the doctors asked this question at the beginning to Prof. Peter Openshaw, if you remember, and that was a fascinating answer he gave. He said, I will take whichever vaccine my GP gives me. I will rock up with my sleeve rolled up and I will be the first to take it. That was our answer. So that I think the key is they're all safe. and they're effective. And the first one, when we're called, we take the one that comes to us, and the government have done a really good thing by bringing different suppliers to make sure that we can manage a supply chain and not just reliant upon one. I personally had my Pfizer, and that's the reason, because Pfizer was the one that was available at the time. If I hadn't had my Pfizer, I was given the AZ, I would take the AZ. I was happy either way, whichever one was available. There are some patients who can't have the Pfizer, maybe because of severe allergies to the ingredients. It's very, very, very rare, but we will check that with you anyway, and again with the AZ. So anyone else want to comment on that particular question about the type of vaccine? Okay. Next question. Oh, it's a good one. So why does the government, so we talk about trust, aren't we? So the government has come up. Why does the government want to leave a 12-week gap before the second dosage when the tests have not been done to see how effective it is? I'm thinking it might be Uma who answers that one for us, actually. Sorry to put you back on the spot there, Emma, but I know I asked you this question just last week, didn't I? So
no problem. So the 12-week gap is, I think, a very reasonable question, and it's something that's been raised both within hospitals professionally and in the community. And if you look at how the vaccines were trialed, the Oxford vaccine was actually trialed with a 12-week gap between the vaccine doses. And in the group that had a 12-week gap between the vaccine doses, there appeared to be a higher vaccine efficacy, it appeared to be more protective. So in the case of the Oxford vaccine, the AstraZeneca vaccine, there's good evidence for vaccinating at week 0, and then vaccinating 12 weeks later and having an improved efficacy in that. The question becomes one of why we're doing it for the Pfizer vaccine. And Pfizer recently made an announcement affecting all countries in Europe, stating that they will not be able to deliver their planned deliveries for at least the next quarter. So it looks like for quite a considerable period of time, we're going to have a shortage of vaccine relative to the number of people that we need to vaccinate. And in order to get on top of this particular problem, we need to have at least 70 to 80% of the population immune to the virus. And given that we're not going to be vaccinating on children and pregnant women, that would mean anywhere in the range of 70 to 80% of the population being vaccinated. And in a population of 67 million, that's a huge number to cover. Which would mean something like 120, 130 million doses of vaccine. So for the foreseeable future, there will be a shortage relative to the number of people we're vaccinating. And we are at present prioritizing people who are likely to develop severe infection or who are in the high risk groups for dying if they develop severe coronavirus infections. And then subsequently, everyone else within the general population will have access in order to stop the transmission. So in this situation, the question becomes one of how do we sort this out? We have a shortage of vaccine. Do we then ensure that we have a small number of people who are vaccinated twice? Or do we try and vaccinate everyone? And the way of looking into that is to then look at what happens when you vaccinate people once with the Pfizer or the AstraZeneca vaccine. And there seems to be reasonably good protection from that. In the case of Pfizer, we're looking at protection of around 90%. In the case of AstraZeneca, at least 70% after the first dose. And in that situation, it may be reasonable to vaccinate as many people as possible with the first dose in order to reduce the risk of the individuals you're vaccinating developing infection and reduce the amount of transmission within the community as quickly as we can. So the reason for the 12-week is because of the ongoing and likely foreseeable vaccine shortage in relation to demand.
Thank you, Emma. And I guess, to summarize what I'm hearing from that is Oxford, there's lots of it. It's from Oxford, it's local, isn't it? So we've got it, we've invested, it's actually Dr. Ramaswamy's niece is one of the lead investigators, one of our local GPs, and it's, it's known, it's trusted, it's local. Pfizer is also known as trusted. It's in short supply. One dose of Pfizer is going to reduce your risk of dying. And 2 doses gives you more super immunity, but it's about spreading out enough that those who are really at risk aren't going to hopefully succumb to the worst outcome, which is mortality. So thank you for running through that, Emma. The next question is, I don't mind who answers this question. I know it won't be me, if that's okay. I'm the one going to be throwing you all the tricky questions. Is it true that vaccination contains aborted fetus cells? And all the other things that have been coming up in the chat about what it contains. What does it contain? What's in this vaccine? I know you've already sort of talked it through, but let us know what's in this vaccine. Are we going to hand over to Uma? Yeah, Uma, yeah, and maybe Sarah. Anyone else who'd like to come in as well? So Uma, if you go first and explain it to us.
So I think this stems from the concerns around the Oxford AstraZeneca vaccine. And the difference between the two vaccines is that the Pfizer vaccine is entirely synthetic. It's completely made in the laboratory. It contains mRNA, as we spoke, this message that codes for protein, and a fat layer, some sugar, some salt, and water. That's essentially the basis of that, and polyethylene glycol, which is a complex sugar. The Oxford vaccine relies, if you think about it, as a delivery mechanism. So it relies upon this, using this cold virus as a way of getting the vaccine into the cell. We know viruses infect cells well, and this is a way of making use of that instead of causing illness. And it's a cold virus that can't replicate. So it can't reproduce, it can't cause infection. So it contains that, it contains amino acids, it contains a bit of salt, it contains some sugar, and a tiny bit of ethanol. In fact, less ethanol than there is in your daily bread, and water for injection. So those are the main constituents. But because it contains a virus, and viruses can only reproduce in cells, in order to make it, it's made up in cells. And the cells that it's made up in originally, many, many decades ago, came from a fetal cell. So a fetal cell was obtained, and then that has been, that as the precursor to the cells that are used within the laboratory. The vaccine itself does not contain any human cells whatsoever.
That's a perfect answer. Thank you very much. That was a really important question. Okay, so the next question, is it possible to get a second dose after 21 days if it's the Pfizer vaccine? Sarah, are you happy to answer that question?
My understanding is yes. They're not. It's a changing feast, isn't it, Umar? So basically, at the moment, the aim would be to get the people that had first doses of Pfizer to have it within the 3 months or within the time frame. But if more evidence arrives that we who have had our first dose are still immune, then they may push the barrier out. But at the moment, there is all intent to give us all our second dose within the time frame told. So yeah, and I think that will happen. There's no conspiracy here. They will do this when the supplies come in.
Completely. So again, for the previous question, as soon as it's ready, we'll get our dose. So you get called for your first dose, you get called again for your second dose as soon as the supplies are there, but within 3 weeks, not at the moment because of the supplies. So the next question then, I guess, is again, the previous question, is one vaccine more or less effective than the other? And we talked about that already, but is one less effective in people who are immunosuppressed? And that worries a lot of us, doesn't it? If we're shielding or, which one's right for me? That's an important question. If I'm immunosuppressed, is one of them less effective for me? Sarah, you are on Spotlight, so you can answer, but I may...
I think Umar's better at this one, yeah.
Yeah. Dr. Umar, can you answer that for us? Or Dr. Shah, Professor Shah?
So, shall I briefly say something on this? It's in the context of the immunosuppressors, the question suggests, the issue is actually that they may not respond as well to vaccination as everyone else. There's no risk to them from the vaccine. That's, I think, very important to bear in mind. And I personally, if I were immunocompromised, I would, as I have currently, just take whichever vaccine is there, because in terms of their efficacy, they are similar, bearing in mind that at least in one group for the AstraZeneca vaccine, we saw an efficacy of 90%. That was in a younger cohort and individuals in the UK, but that can be achieved potentially. And we expect these vaccines to retain their high efficacy in whichever cohort they're assessed in. When Pfizer carried out their trials in a subgroup who had HIV, and Oxford as well, there doesn't appear to be a significant decline in vaccine efficacy.
Thank you. And I've noticed that we've actually got 28 questions in 15 minutes. We're going to have to really speed up. So I'm going to just hit you quick and fast, okay? So let's see how quickly I can go. Okay, another question around the government, which we can probably come to after we do the rest. But I think, again, that goes back to the mistrust and trusting question. Will the vaccine become mandatory? Some companies are already making it policy. Well, so far, no. It's not, it's a choice. Everything's a personal choice. Nothing's going to be forced upon you. Today in the news, they said even if you had your second dose, you are still not guaranteed that you will not get COVID again. And that's right. So the second dose of Pfizer is 95%. So there's that 5%, isn't there? And it goes back to what Prof. Harinsha was saying about, do make sure that you're still washing your hands. We've got to still wear those masks. We've still got to socially distance. In time, this will of course change, but we've got to do all of it together. These are all different parts of how we're going to overcome where we are at the moment. So can you see family? Can you stop social distancing? No, because if we saw recently in other countries who have done the mass vaccination programs, people are feeling a lot freer, which is a great feeling, and going out. But unfortunately, that's 95%, isn't it? And that's still a critically high number of potential infection in the community that's circulating. Anything else you want to say, and anyone else before I move on to the next question?
Can I just add something? Yeah. The time when we're able to dispense with or do away with the basic measures that we have, social distancing, hand washing, and masks, will be when the rates of infection in the community are very, very, very low. So that's likely to be once we've vaccinated, or at least 80% of the population are immune.
Okay, so the key message here is you all need to do our bit as citizens to ensure that we can go back to having that lovely normal life. It is 2021. It'd be so nice if sometime during this year we could go back to a normal life. Okay, this is an interesting question. Maybe Samira, because you're our engagement lead for North West London. Given that misinformation on social media is very unhelpful, is this a good idea to use social media for putting out accurate information, or does this just confuse things? So many messages. Samira, can you answer that question for us, please?
So I don't think we can get away from social media and the impact of social media. If we saw how prolific the information was shared, the misinformation that was shared at the early stages, I think social media is critical in helping us actually kind of share the messaging. I think my ask of people is that you look at the source of the information that you get, and who is sharing the information from you. Have you validated the information that you've got, and what sources of information that people are getting? The second is that just before you share it with others, is make sure that actually it's based on scientific information, on medical advice. It's not just somebody who said that something happened or something has been put together by a group of people who that then gets shared. So I think we have a duty as for our communities to actually share things that we know have been confirmed as accurate, rather than sharing things that we know we can't really kind of validate the sources of.
I think that's important. I guess that's what today's about. So hopefully we'll put today into, when Abdurrahman downloads it into that mini video, so we can circulate the information and get the messages out there. And I think,
add something.
Yes.
And just to say that when I had my vaccination, there's an information sheet that is given. And I think that information sheet is exceptionally good. It covers a lot of the discussion we had today about immunosuppressants and times and so on. I wonder if there's a way of getting that information on a website somewhere that's more accessible and not waiting until you get the vaccination.
I think that's a very good point there, Prof. Shah.
It covers everything, lots of our discussion today, really, in 2 pages. Yeah.
I'm going to ask Dr. Baines now to find the link and post it, maybe. That would be fantastic. So you're right, before you go for the vaccine, read up. We are sending out information in advance, but you're right, why not take the whole thing? Why wait till after? Have it so you're really confident before you go.
Sorry, just one quickly. What I'll do, I'll also look at the data and see if the information sheets, and we can upload it on our Healthier Northwest London website so people can access it too.
Lovely. I love meetings with action. So here we go. We've got an action. So everyone think about the actions they're going to take. So we've got 10 more minutes. Let's see if we can get everyone to take away an action. Hopefully the action is to take the vaccine, but maybe it's not. Maybe it's something else. Okay, so I guess the next question follows on from there, Prof. Shah. What are the side effects, if any, of the vaccine? I've had mine, I'll be honest, it hurt my arm for 2 days. I could sleep on that side. So if you go for your vaccine, pick the arm you don't sleep on. But when you have the vaccine and it's working and it's giving you a side effect, know that that's the vaccine being quite powerful, having its effect. So I felt quite happy I felt it, to be honest. Can someone please answer the bigger picture on the side effects for me, please? Maybe Dr. Baines, because you're the one giving your super vaccinator, aren't you, at St. Charles? You're probably saying this every day about 100 or 200 times, Dr. Baines.
I was just putting something on the chat for you, a link. So I think I heard that correctly, which is what are the main side effects. So there's something what I talk about in terms of my my description when I'm vaccinating patients is that the main side effects are a little bit of a sore arm afterwards, mild headaches, and mild flu-like symptoms, and they usually go away within a few days. If you do find that you're getting a little bit of a sore arm or a little bit of muscle ache, then feel free to take some paracetamol. That's usually something that will help sort it out. When I had my vaccine, I had a sore, heavy arm for 2 days, and it went away. As Jasmine said, it's just literally difficult to sleep on, but that was it really. So they're the main things that we talk about, Jasmine.
Yeah, and the second vaccine might give you some more side effects than the first vaccine. So even though you had one, you got a really good boost at that point. So just be prepared for that as well, and keep some paracetamol with you. No one's had any severe reactions. Someone's asked a question in the chat about death from vaccine. Now, no one has died from the vaccine at all. That's really important. We've already answered it before, but I've left it in our Q&A just so I can raise it again. The vaccine is safe. We wouldn't take the vaccine ourselves, obviously, having read all of this up. Dr. Baines and I were the first to go and take our vaccine when we were called, weren't we? We made sure, actually, that we were there. Okay, so other questions, probably for Jeffrey and Dr. Baines about the where as well, and the recall. I know we've already talked about it, I guess, but I've got patients here who are saying they're living 5 minutes from St. Charles. They're in the shielding category, but they were asked to go to St. Thomas's. Why is that? If I'm shielding, does it mean so if I've got COVID-19 and I'm shielding, does it affect my vaccine? So questions on shielding. And there's one more question about the location. Which one will be rolled out in North Ken? So Dr. Baines and Jeffrey, just talk a little bit about where you go for your vaccine and what the difference is between the shielding groups and what we're doing at the moment in terms of rollout.
So I know that, so I don't know if Jeffrey and Sarah want to say a bit more, but I know that people who are under the care of hospitals, they may be offered their vaccine there. So I think from what you're saying there, somebody is shielding, may well be under outpatient care from a hospital. And so that's where they've been offered the vaccine first. And then if you happen to have your vaccine elsewhere, like in a mass vaccination site or in a hospital, what's happening is all the information on vaccination is going to one central site. And so you technically shouldn't be offered another repeat invitation from your general practice, from your GP practice. So that's sort of how it works. And then with regards to the local, I think, Jasmine, you said something about the local sites. So our local site around here, for our practices around here, we're offering the vaccine at St. Charles Hospital. And that's where a number of our patients who are registered with a GP practice in this locality are being offered the vaccine, although there is an option if they wanted to go to the 2 vaccination sites in the south of the borough, but this is the one that's nearest to us here.
And then a question that's come actually is about if you're shielding and you're living in W10, you haven't had the recall yet, and that's right. So we have to do all the over 80s and all the over 75s before we can move down to over 70s and shielding. And every day, quite a few emails go around on that to all the doctors to make sure we're hitting the targets for over 80s and over 75s. So hopefully this week we'll be able to start with the over 70s and shielding, but it really depends on getting the uptake right on our over 80s and over 75s. You will, however, have received a letter from the government for the mass vaccination sites. So if you'd rather go to that in the meantime, you're eligible to go to that, but maybe about a week's delay before you can have, if you're shielding, at one of the GP centres that we're running. The question that someone asked about, can you have the vaccine if you've got COVID? We recommend waiting 4 weeks because you get a much better response from the vaccine 4 weeks after. So if you had a positive COVID test, you're still eligible. And if you miss your opportunity to have your vaccine because of a reason like that, and you know, people are travelling and they're stuck outside of London, aren't they? Then that vaccine is yours as soon as you want it. If you had to have a reason why you couldn't have it, you just ring us up. Or if you said no, I didn't want it, and you change your mind, please click on that link that we send out to book, or ring us up, or, you know, answer the letter. We are, you know, there's a vaccine for you. Jeffrey, anything more you want to say on the sites there?
No, I think that covers it. Thank you.
Thank you. Someone was asking, will we be recording? Yes, we are recording. If they say the vaccine is safe, why have companies been given immunity from prosecution? Who's going to answer that question then? I like conspiracy theories. I just don't know the answer to them. So who's going to be able to answer that one for me? I can't pick an again.
Well, I think one of the reasons behind this was that because the normal speed at which vaccines come onto the market, generally 5-10 years or so, with most vaccinations, there was always an element of risk initially. And the companies had negotiated that, to my knowledge, very early on with the government, that there would be, in this case, exempt from any of that. Not that they were scared, but it's just because the technology was new for the time. I don't think they were worried about there wasn't any sinister reasoning or so behind it. It's just a question of time. But as Omar made it very clear, I think there wasn't a problem with this.
Yeah, I agree. They're very, very, very safe. No shortcuts have been taken. Just all the right processes have been taken just to make sure we can get the vaccine to you quicker. Someone's asked about a 99-year-old neighbour not being offered the vaccine. It may be because they're housebound, they can't get to the site. The housebound vaccines have just started this weekend, and we're working very hard with our community teams on the weekend to come out. So please, if they can ring their surgery, there are roving teams going around with the doctors and the pharmacists to deliver vaccines. If you know of any neighbour of yours who is eligible and hasn't received their vaccine, please just give us a call. We really, really want to get everyone's vaccines delivered. So if for any reason they've missed the call from their GP, and what we're finding, people don't have a mobile phone, they may not get a text message. Of course, that's a really easy way, isn't it, to get a text message reminder. At 99, they may not have that text function. So please, on their behalf, do phone us. You know, the vaccine is there for them, and it may be the housebound one. Okay, so we have only a few more minutes. I'm going to run through the last ones. Is it going to be an annual program? Yeah, I guess probably, isn't it? As the virus mutates, as the flu season, you know, it will ongo. Does it affect fertility or future fertility? Not that we know. There's no evidence to say that it does. Can we have a copy of the Q&A? 100%, that lovely person who's typing it up for me, please do email it to us. Or we can always replay back and type up. These are really, really valuable questions. It's so important everyone gets their questions answered. I'm in the CEV group. Yeah, if I miss my slot, what happens? Exactly. If you miss your slot, you just come back again and say, I'm here, and we will give it to you. Germany's making medical grade face masks mandatory. Is that likely here? I don't know. I'm assuming it feels like it is almost mandatory, isn't it, that we're walking around in masks in the street? But it's again, is that part of us being a citizen in society, and you know, not needing the police to come and tell us to put the mask on? But I guess we're all coming quite used to those masks. My tip for the mask I learned from an asthma specialist is put a little bit of essential oil in there. It smells really nice. It's really relaxing and peaceful. It's gorgeous, actually. I like my mask. So open your mask, put a little bit of a nice drop of something you like, some lavender or some lemon, put it in there. When you're breathing in, it's a lovely thing. And of course, change your mask, wash mask. We had a really good advice: treat your mask like you would your underwear. So please wash it every day, or dispose of it if you're not, if it's a disposable one. Children under 13, not at the moment, no. Okay, side effects again. Someone's really worried about the Pfizer side effects. Uma, can you answer that one again? There is anecdotal evidence that a very small percentage of people having reaction to someone said about the Pfizer, and someone's very much worried about losing their life. But there's absolutely no evidence or no cases of that whatsoever. Is there anything else, Uma, you want to say on that?
The Pfizer vaccine is incredibly safe. It's been followed up following 20,000 people having had the vaccination. And the concerns that they may be relating to here might be related to the news from Norway, where elderly individuals in care homes with multiple medical problems, very frail individuals, were given the vaccine. And 23 deaths are being investigated because they occurred in chronologically close to the vaccine. So they occurred after vaccination, not because they were caused by the vaccine, but because they occurred after vaccination. And so the government has requested there that people who are very advanced in age and very frail may not want to have the vaccine.
Thank you.
But there has been, as you stated, there has been no death associated with the vaccination.
Yeah, so important.
And the side effects that we see are side effects generally that we expect to see as a result of having a vaccine, and they last for a short period of time.
Yeah, the side effects will pass. And call us if you have any questions. If someone's asked if they're not registered with the GP, can you self-refer? We would say register with the GP, because then you're on the system and we can do all the safety checks for you. Of course, that's the way to get in, and it's very easy to register with the GP. Everything's now online. I've got one more question for Uma that we'll probably like to finish on, but I'm going to just make sure I want to answer all of these. So, does the vaccine contain pork? No. Don't worry about that one. The nasal flu spray has a bit of gelatin, doesn't it? But this one it's a no. So it's halal, it's kosher. Would you recommend, which vaccine would you recommend? We discussed that already. So that's important. People who suffer from immune conditions, can they have the vaccine? Yes. As Uma said, if you're immunosuppressed, any response to any vaccine might be less. So you still have to protect yourself, but the vaccines are safe. Is there any research on blood type and COVID vulnerability? Well, I think Prof. Garbia might be the one to answer that. That's Prof. Hiren Shah's wife. She's not on the call, but we can take that question to her and definitely come back with that one. I don't think any of us probably have the answer to that one. And nearly there. I'm allergic to iodine and penicillin. Can I take the vaccine? So initially there was this worry about having severe anaphylaxis. Could you have it? And the answer was no. And now they've said if you have severe anaphylaxis, any of the ingredients in the vaccine, and Uma's talked through what those ingredients are: a bit of fat, a bit of sugar, a bit of water. There's not too much in that vaccine. So if the answer is yes, you can. If there's a severe allergy to something unknown, and we don't know what it was that caused anaphylaxis, then we're saying that just don't have the Pfizer vaccine. Okay, but we're there the entire time anyway with the medical kit to the whole team. There's a team of 30 to 40 staff running the centres.
Jasmine, I just wanted to add in there, it's Manpreet here. I just remember on the chat earlier, I've been trying to keep an eye on the chat, and I'm sorry that we haven't managed to answer all the questions on there, but there was something earlier about how do we know are people being monitored after the vaccine in case there's any issues, and we do keep people for the Pfizer vaccine 15 minutes after it's administered, and as Jasmine just said, we keep full, and if in case anyone has a serious reactions, but highly unlikely, but in the rare event it happened, we have the full equipment there in case of any issues.
Yeah, and we've been running for quite a few weeks now. The only thing I've seen is someone felt a bit sick before and vomited after, and that was it. Everyone else comes and goes, yes, it's a great feeling when you have your vaccine. And make sure you've got your camera to take a selfie, because I think that's quite nice as well in the centres, to make sure you have talk about social media, make sure you take that picture. Okay, so we are going to end. The last question, it's a good one. Those who need to leave, do leave. What I'd like everyone to do before they leave is finish that Mentimeter and tell us where you are now on that scale of 1 to 10, wanting to take your vaccine. So I think I have to press the forward button for that to happen. I think I do. So let me see. So following the session, how likely are you now to take the COVID vaccine? So fill that one in. So where are you now? Where are you before? Where are you now? You could be the same. It could be worse. It's just where are you? If you're towards 10, we may be seeing you next week. It'll be exciting to see you all in person at the centre. We do look a bit different, obviously, with our face masks on. You might not recognise us, but hopefully will. Dr. Baines and myself are up there at St Charles Hospital. And Dr. Elkin and Dr. Umar are in the other hospitals at secondary care. So that's fantastic. So I can see that's really going up. That's really, really good to see. Thank you so much. And I'm going to just check the last question. I think it's a good one. So those who want to stay to have another story from Dr. Umar, because I'd like another story. I really liked his storytelling style, actually. And I'm thinking when we do cut this one up to put this on YouTube, I'm going to make sure we capture that one for definite there. Dr. Umar, tell us the question. Why can we not let our own bodies build their own defences rather than being synthetically injected? Handing over to you. And those who need to leave can leave. This is a nice bedtime story for all of us so we can relax into our chairs and enjoy Dr. Umar. And then we're going to close there and thank you all our speakers.
So one of the main challenges throughout the past year that we've seen is that people can present with coronavirus very, very, very differently. I had coronavirus apparently, and I know that because I've developed antibodies to it, but I never had an illness that was particularly severe and required me to stay in bed, if you like. But the other week, I was sat at the end of the bed of someone who, despite us giving him large amounts of oxygen, almost 60,000 liters of oxygen a day, was holding my hand and thanking me for the care that he had had because he wasn't getting better on that oxygen. And we knew that they had a limited time on this earth. They were alone. Their wife of 50 years wasn't with them. Their children were nowhere near them. And all they had were the nursing staff and the medical staff and their fellow patients in this 4-bedded bay with oxygen just being pumped in and knowing that they weren't doing well. And for me, that was harrowing. For me, it was an incredible honor to see this gentleman so noble at the end of their life. And that is the problem. We do not know who will become very unwell. And I wouldn't want anyone to be in that position. So I don't think it's fair to expect people to take on this burden by themselves without taking hold of a means that we have in hand where we can safely and reasonably, reliably protect people. And that's the reason why I think we shouldn't allow the virus to rip through our population.
Thank you very much. I think that's probably a really important question to end on and a really important point to end on. I feel like having my second vaccine now. I've already had my vaccine, but I feel like going and making sure I'm in that queue and it's my next turn again next time round. I think that's so important, and making sure we are really protecting not just ourselves but those around us. And thinking about that bigger picture, as Samira said before, in our communities, and Sarah said before, in our hospitals, and the impact of those who have survived, the long-term impact with long COVID. And as Prof. Irene Shah said, you know, please wash your hands, still stay socially distanced, wear those masks. There are some really amazing masks out there now, aren't there? I've seen some fantastic ones. You know, it's part of life now, but we are going to be able to get back to normal once we have as Umar said, an 80% uptake in our population. So do encourage your neighbours, do encourage your friends, do ring us if you're waiting for your vaccine and it's your turn. Your vaccines are there waiting for you. I'm going to say a very big thank you to Manaar for hosting this on our behalf. They've made it incredibly easy on us and created the meeting space and the link and the opportunity to really engage with our community, and to the council for doing their best to work with the NHS and make this happen. It's tremendous what change has happened. You know, we have been redeployed to do this. Who would have thought we could do this? We could only do this because we're doing it together. What we'd really like is everyone on this call who is with us on this journey, part of our community, to support this endeavour to get our population vaccinated, to get that community immunity, to keep us strong together. And when you've had your vaccine, do come forward as a volunteer as well to run the centres. We've got lots of volunteers coming, helping people through the sites to make it easy on them, to make sure that you have a good journey there and that you're safe and that you're protected. So again, thank you to every single one of our speakers. I hope I haven't missed anyone out on my list. I'll just make sure I say it all over again. Abdurrahman, Dr. Elkin, Samira, Prof. Harun Shah, Dr. Ibrahimsa, Jeffrey Lake, and Dr. Baines. Thank you very much, and thank you to everyone who's joined. We've answered all the questions in the Mentimeter, which is fantastic. If there are any more that come on the Zoom, obviously we'll have a look at those after. We'll let everyone go and have a nice dinner, cup of coffee, look outside and see if there's any snow left, and see what's going to come to us tomorrow. Thank you and good night.
Thank you, Dr. Jasmine, for facilitating this perfectly well. Thank you, all of you. Thank you very much.
Thanks very much.
Thank you.
She's very good.
Yeah.
She keeps it alive. She's invited to some.